So thank you very much, Indu. It's always a pleasure meeting Dr. Indu Khosla and all other people. And now Dr. Manjari also has come here from AIIMS. And today, I'm sure the conference has been progressing very well, and it's being transmitted all over. That's a very good point. Now we're going to be discussing about what problems child with asthma, which is actually my bread and butter for practice. I'm a trained pulmonologist, and we had been doing carrying the burden of sleep studies always. And we now think that we should have a pediatric sleep department also, like a separate center or part of the overall sleep center. So this presentation, which we are going to give you, is first going to be made. The case is going to be presented by our first DM, pediatric pulmonology and intensive care student. Her name is Khusboo Taneja, and she's actually made the presentation also, and she's going to present it. And we are going to discuss about the various nuances of how an allergic disorder or asthma affects sleep of a child and how it can be associated with something even more than that. So Khusboo, you can please come here and start making your presentation, but just keep your speed low.
Thank you, ma'am. I have big footsteps to fill. So let's begin with the case. This is a 6-year-old male child, developmentally normal, diagnosed case of asthma requiring GINA step 2 guidelines treatment. And he's been on MDI since 1 year of age, as was advised. Both parents are working in a farm. He lives in a village near Roorkee and he goes to class 1. He was started and advised as having to take treatment in the form of pressure MDI with spacer and with budesonide 100 micrograms twice daily to 1 puff, and reliever treatment in the form of salbutamol 100 mics 1 puff SOS. But since the past 6 months, he's had poor compliance. In past history, he's had episodes of difficulty in breathing and was aggravated by dust and smoke since the past 2 years, and these have required frequent nebulizations at home before MDI was started. Symptom frequency is now reduced since his treatment was started. He also has a history of bouts of sneezing, around 15 to 20 episodes per bout, when his mother is cleaning the house, which is almost daily. And he has no history of food allergies or any drug allergies. In family history, his father is a known case of bronchial asthma, and he was born out of a non-consanguineous marriage, with his birth order being the 3rd, and his other siblings are completely normal. The mother has no history of recurrent abortions, and there is no history of TB contact. He has been immunized as per the NIH schedule up to age, but influenza was not received.
We can stop a little bit here. So basically, this 6-year-old child who has presented to AIIMS Rishikesh with respiratory complaints of cough and wheezing, and is actually a diagnosed case of asthma. So when we are discussing allergic disorders, we are also taking into account not only the respiratory complaints, the chest complaints, we are also talking about nasal symptoms. And we just had discussion about, how airway obstruction can lead to problems that can affect the sleep of children. So in this particular scenario also, this is a child who has an allergic asthma. Along with that, he has very predominant nasal symptoms. He's been having 15 to 20 sneezes in the morning, and mostly that is in reaction to whenever the mother is sweeping the floors or dust is into the environment. So this type of story, most of the times, we stop with giving these patients inhalers. We think that their respiratory complaints will get better. At the most, when we are looking at their nasal symptoms, we also advise them about some antihistaminics or sometimes nasal steroids to keep the airway patent and the inflammation low. We usually don't ask about, any other problems which the child may be having, which these children always have. For example, their quality of life is always affected because of their asthma and allergic disorder. And that quality of life is determined by their symptoms and signs, which also occur during nights. And we know that in asthma, most of the times the symptoms are there more at night time. In fact, more so during the early hours of the night late hours of the night or early hours in the morning, when they wake up with a cough, and that is something which we use as a diagnostic point for an allergic cough. So, but we don't ask them, what is their sleep like? We don't ask them whether they are not sleeping because of their symptoms which occur at night, or there are some other associations also which are happening in these patients. Most of the time they have a nasal block. If their nasal symptoms are not controlled, they will continue to have chest symptoms as well, as we always teach them, but you should always treat the nasal symptom, and this is what is known as united airways, that you have to treat the upper as well as the lower airway to get the best control of asthma. We know that a good control of asthma will certainly relate with better quality of life, but the quality of life will certainly improve if we ask them about their other parameters which affect the quality. And sleep is very important out of that. And because of that, because they are not able to sleep sometimes at night, they may not be able to perform very well during the daytime. In the class, they will tend to sleep. And we have had patients, where the teachers have complained that the child keeps on sleeping and is not able to concentrate. And sometimes they are misdiagnosed as ADHD, that they have attention deficit, where the problem is that they are not sleeping at night, and that is because of their asthma or allergy. And that is the main issue which has been happening. So these are some of the issues which we will be discussing. Plus, this child has something extra as well. So now we can proceed further.
Thank you, ma'am. The development history, the child we asked was appropriately developing for age, and socially he had a good friend circle and no complaints from school and peers and teachers. But recently, even the teachers saw and the parents also noticed that he had been more irritable and short-tempered, especially at home. So in the last week, as we made the same mistake that ma'am pointed out, we only asked particularly initially about the asthma symptoms and the control that we scored. He had 2 nighttime awakenings, which were associated with shortness of breath. 2 times he had to use a reliever MDI, and he had 1 episode of shortness of breath in school during his physical education period. So the parents, in fact, here told us upfront that he was not able to sleep very well since the past 6 months.
This is a new story, which has come up along with what the child had. We thought as physicians that we have treated his asthma, we've done something about the allergic rhinitis, but now the parents have a fresh complaint for which they have come. They have not come because of asthma. They think it's okay.
So they said that he was not able to sleep very well since the past 6 months, which had gotten worse since the past 2 months. He kept moving in his bed, appeared irritable around bedtime. He often cried while trying to go to sleep, and he had no bedwetting episodes though. During daytime, he seemed more lethargic, and he didn't appear to play and as energetically as he would have. And in his morning school also, the teacher complained the same.
So whenever there is a problem like this, that the child is restless in the bed, sometimes the dinner has finished and then he's going off to sleep, going to bed. Many times these patients also have what is called as gastroesophageal reflux. I mean, that is another thing which happens, and that precipitates asthma, cough, and other things, because it leads to whatever contents of the stomach are, they come to esophagus or to the larynx, and sometimes aspirations will also occur. So patients who have gastroesophageal reflux, which is associated with asthma, can also have this kind of symptoms. That means, and it is also very well known that these children, when they, during the night time also, most of the times the parents, they assume different postures in the bed. They would try to crumple up because they are trying to resist that reflux which is occurring. But then there are certain reflexes which have been defined, which are neurogenic, which may happen in these patients. They also get activated, and so that also is something which may be affecting their sleep, along with this discomfort which is occurring to them. So this particular, once the children are, when the children or the parents are complaining that child is having problems while going to sleep, that is one thing we think of. And we advise them about taking light meals. We advise them about taking a pillow so that they are a little inclined when they are sleeping. Or many times what happens to them is that they also have some, some salivation which occurs, and they tend to kind of wet their pillows. So these are some of the features which we talk to them about and try to make a diagnosis clinically of GI reflux. But then there are other features There's something in addition to that which was there, so which will make us think of something more. Yeah.
So as ma'am was saying, the awakening which had happened, which were related to any respiratory problem or any drooling or postnasal coughing bouts were only that week. But prior to that, since the past 6 months, he'd had 6 months of pain or any weird sensation in his legs. This was gradual in onset. It was a continuously present symptom with most of the nights, the symptom being present. It was worsening in severity since the past 2 months. He had some pressure that he wanted his parents to be put over his leg for him to be relieved. They had to massage his leg around 20-30 minutes, which helped the child finally fall asleep later into the night. And his symptoms also improved. He was allowed to run around or play in the night or watch some movie as a distraction.
This is another thing which happens, in children. It's very common that whenever they are going off to sleep, they start complaining of pain in the legs. It's a very common complaint. And most pediatricians will call them growth pains. And they will try to tell the parents, these are growth pains, the child is growing, and you give him calcium or you give him a lot of milk and vitamin D, and this will improve. And this is a very common advice, and the first level advice which is given to these families. So growth pains is something which always comes in the differential diagnosis, and a lot has been written about growth pains actually. Sometimes, we have seen patients who are walking, also they're limping around it because they have some problem which we think could be growth pains, but actually they are not. Sometimes they may have epithelial inflammation or something like that, which could also be there. So that is another differential diagnosis which comes to mind when there is a complaint of this type. Yes.
So they persisted that already they had gone to some private practice person who had given them calcium earlier, but the symptoms had still persisted. So now they came to us with these symptoms which they were worried about, and hence we tried taking history from the child through a standard symptomatic approach questions.
Now you know what we are coming to, what we are trying to discuss actually. This is, we are trying to ask questions about restless leg syndrome. This is one condition which is the prevalence of which we are not very sure how much it is in India because no surveys have been done, but in West, I think it is very common. And post-COVID, it has been becoming even more common. And even in children, because although COVID was not very harsh on children, but still they had the features which were more consistent with long COVID. That is, after the infection, they had problems, and one peak of that is when they get that multi-system inflammatory syndrome. But before that, they start having these sleep disturbances. That is one, and pains, aches and pains here and there. So that is another thing which happens. But what we wanted to decide about now is whether this child has what is known as restless leg syndrome, which is a diagnostic entity and for which diagnostic criteria have been laid down. And in pediatrics, also this is a very important condition which we discuss about.
So as the child said, he had some pain and weird sensation in his legs, especially in the calves. And this was what he came up with when we asked him directly. Also, he said that he felt better when he watched a movie or he moved around and his parents were playing chase with him. And he could only fall asleep when his papa massaged his leg. And then he did not feel any other symptoms in the daytime. And this was not even present when he was sitting still or studying in his school.
So watching a movie is something very, very interesting now in this child. If he has a phone, say a mobile phone, most of the time they have mobile phones and if they have access to internet, they would have access to movies. But how much that affects the sleep of the child? Here they're saying that watching a movie would actually distract him away and probably he feels better. He doesn't feel his pain or that discomfort, whatever is occurring to that extent. But watching a lot of blue light screens is something which is affecting sleep of individuals, whether they are adults or their children. And I don't know what the opinion of the house is about effect of screen time on sleep time. And it's been seen that the screen time in the evening, especially before going to bed, has an adverse effect on the sleep time of the child. And so that is another factor which we have to advise to these children not to do if they have to fall asleep properly. So what is your opinion about sleep? person.
Yeah, so the retinohypothalamic pathway where your melatonin is secreted by the pineal gland, so exposure to blue light will inhibit the production of melatonin and therefore hence will delay the onset of sleep. So definitely screen time, and there are a lot of studies to show that screen time has decreased the total sleep time in individuals, and it has affected their daytime functioning and even cognition, behavior changes, hyperactivity, irritability. More and more kids who are hooked on to the mobile phone, we call it today an and then you start communicating with the child, the speed starts developing. So we are seeing autistic features in children who are hooked on to screen. And that's a very scary thing. The number of kids we have seen like this is mind-blowing.
Very right. And another very important aspect of the screen, watching the screens and the phone is its addictive potential. Actually, there was a professor in Canada who has written that if you give a pinch of heroin to a child or you give him a mobile phone, it's one and the same thing. And that is what is happening. As you said, they are like electronic nannies. When the parents don't want to look after the child, they'll give him the phone and give your child off the that. And you must have seen even in the wards, in the hospitals, where children are just sitting with their mobile phones. They're watching, they're either doing video games or they're watching some cartoon movies or something like that. But how much harm that is likely to do to the child in the long run is something we must be very, very careful about. And one aspect of that is that does affect the sleep. So this watching movie could be, a problem here. Yes.
So this is a figure showing the relationship of asthma and various sleep disorders. Asthma is correlated with hypersomnia or early disturbed sleep pattern, or insomnia or circadian rhythm problems. Parasomnia is movement disorders like RLS, and sleep-related breathing disorders, which are seen to be correlating with the severity of asthma itself.
So there are different kind of disorders of sleep which can occur with asthma. Although this particular child has restless leg syndrome, possibly, but there are other sleep disorders which would also occur. Next.
So in general physical examination, his vitals were predominantly normal. He had a normal saturation on room air. He had a respiratory rate which was within normal limits, and heart rate was normal. There was no obvious distress, although he had allergic pointers like Denny Morgan folds, conjunctival congestion, and his on nasal examination, his inferior turbinates were seen to be enlarged and edematous. There was no clubbing, cyanosis was absent, and there was no predominance of venous congestion or any other signs as such in his legs. Anthropometry was within normal limits. Yes. He weighed 20 kgs, which was between median to -1 standard deviation for age. His height was 113, which was between median to -1 standard deviation for age. His BMI was 15.6 kg per meter square. Centimeter square. I'm sorry for the error. Median plus 1 standard deviation. On systemic examination, he had air entry which was present in all areas of auscultation, although there was occasional wheeze which was present in more than 2 areas, which was polyphonic, present more in right than left and over the mammary and interscapular areas. There were no other added sounds, and other systemic examination was predominantly normal. Just to summarize, this is a 6-year-old male child from low socioeconomic background with normal development and behavior, with good social interaction, currently presenting with moderate acute exacerbation of asthma with allergic rhinitis, found to have symptoms clinically suggestive of restless leg syndrome, or as ma'am said, growing pain is a differential diagnosis which was kept, causing disturbance in sleep and increased irritability, new onset.
So now we invite comments from the house as to the diagnosis of restless leg syndrome, what more we should do about this in this particular child, although clinically it's a possibility. And Khusboo is going to tell you about what are the different diagnostic criteria which are used for these children. And then we will discuss about how to manage this particular child. So any list of you?
So ma'am, when you review restless leg syndrome, particularly asthma does come up as one of the, things which we should associate with, because particularly
there is a hypothesis that the medications used for asthma, particularly antihistaminics, as well as the bronchodilators, both could be provoking RLS-like phenomenology. So one group of people thinks that it is an iatrogenic induced mechanism. The other thinks that it is independent of that. But there's anybody who's done if you have significant number of patients, give one group, continue giving one group the medication for asthma, whatever they're using, and replace it with another, the other group. So if somebody can do such a study, it will prove or disprove this theory of whether the bronchodilators are actually causal. But the association is one of the things which makes us think that it could be iatrogenic. So was the child on any antihistaminic? Because antihistaminics are known to cause RLS.
Yes, ma'am. By literature, even antihistaminics are known to cause. This child was not on any antihistaminics. He was only on MDIs. He was on budesonide and SOS salbutamol, which he hadn't taken in doses which was compliant.
So it could be an independent.
Budesonide will not cause, but the beta-2 agonists, which are usually given to these children, we've seen kids get a lot of hyperactivity with those.
Yes.
The moment you give a child salbutamol nebulization, sometimes they become very hyperactive. So obviously there is a side effect which can affect. And antihistaminics, although people tend to fall asleep, people get sleepy with antihistaminics. The previous generations of antihistaminics, the latest generations are that they are not that soporific, but still, as you said, it may be associated with restless leg syndrome, which is, we don't know the pathogenesis of how this happens, but maybe it has something to do with inflammation, which is there in asthma, allergies, and many other inflammatory disorders. And we're presenting you some data on how asthma has been linked to restless leg syndrome.
Sometimes they're also taking, the mother is also giving them some nutraceutical, like, to generate health in the kid. And one doesn't know whether that has tiny amounts of alcohol in it or some other compounds, like dextropropoxyphene, etc. So many times parents are giving a lot of tonics to their children. And in adults particularly, not only tonics, they give these Ayurvedic compounds, which also have this arsenic in it. So that also generates similar.
One should always keep this in mind and always take a very detailed history of whatever medications the patient has been receiving. So let's move further.
Ma'am, this child was not on any other supplements other than calcium, which he had been started in by private practice in view of growth pains.
Yes.
You differentiate this restless leg from a growing pain? Could you differentiate the two? Was it a growing pain, which is equally common in children?
No, ma'am, this child was meeting the diagnostic criteria as laid down by the group for restless leg syndrome. We did think of growing pain earlier, but then that because the criteria were being met, so it was more in favor of that. Plus, there are some overlapping symptoms, but there are some particular symptoms like relief on massage and relief on rest and activity, particularly, which are not present in growing pain. Growing pain will worsen with activity.
Growing pain typically occurs in sleep. Restless leg occurs before sleep. Okay, so growing pain is generally bilateral. It's pain below the knee and it's released by non-pharmacological method. So even by a good history, you can differentiate the two.
Yes.
Let's go further.
This is great. This is not moving.
Not really. Maybe you can share it again. Just share the link. So all the votaries or, of restless leg syndrome, they now consider that growing pains is actually a no entity. They think that it is actually restless leg syndrome rather than being growing pain. There's nothing like growing pain, but we don't really know whether this is so or not, because growth pains in any case, they would get well of their own. And we don't know whether restless leg syndrome gets well on its own. It's basically, you treat the underlying condition. For example, you have to have a good control of asthma. If that was leading to this restless leg syndrome, so once the asthma is controlled, the restless leg syndrome also will get controlled. And there is a data to show that in patients who are well controlled on asthma, have a lesser incidence of restless leg syndrome in comparison to the ones who are either normal or who are poorly controlled. So that is one, they're kind of a linear relationship for which there is a data actually available, which will be shown. And yeah.
So this is
So
the
these are the
definition criteria.
You could just show them the criteria. I'm sure everybody is familiar with them. So.
As we know, these are the essential diagnostic criteria that the child has an urge to, this is for the adults and children both, that they have an urge to move legs, which is not always accompanied by a feeling of uncomfortableness. It may be accompanied by unpleasant sensation, which may worsen during the periods of rest. This may also be get partially relieved or totally relieved by movement. And this urge can be worse in the evening and night. And this is not also it's a diagnosis which has to be excluded because it has not to be explained solely by the primary condition or behavioral condition.
These are the criteria. So most of them are mostly having this urge to move the legs. And that usually happens before going to bed and gets relieved by certain things, which would be even walking around actually. So these are kind of, you have to really take this history in much greater detail about trying to find out what actually happened to the child at that particular time. I think even a video recording may be quite helpful. This kind of video monitoring of children when they are going into the bed, how they're behaving. So that is something which would be useful. Yes.
These are the special considerations for the diagnosis in pediatrics. Child must describe the symptoms in his own words. The diagnostician must be aware of the typical words that the child and adolescent will use to describe, which may vary, and this has to be a standard way of approaching the questions. The language and cognitive
words are different in different languages in different countries. So somebody may say कि मेरे को ऐसे लगता है जैसे कीड़ा चल रहा है मेरे ऊपर. Some may say कि मुझे कंपकपी होती है. I mean, these are some of the Hindi words which are used because most of the words which are used in the West are not the words which are going to be used in India. It's just like wheezing, wheezing has so many descriptions and so many names. Similarly, I think this presentation of being restless in the legs is something which is going to come from different cultures or from different languages. Yeah.
This is not known if the adult specifiers are actually applicable to kids. They can have a larger vocabulary to describe the same symptoms. It is known that sleep, mood, cognition, and function as an adult is affected in children, but it's more in the domain of behavior and education in children. And periodic leg movement disorder may precede the diagnosis of RLS in kids.
The children, when they are having respiratory distress, they say, "Hame chhati mein dard hoti hai." So they are not able to describe what exactly it is. They may say कि leg में pain हो रही है, चाहे कुछ हो रहा. So that is because their vocabulary is not that vast to describe what these things are. So for children, it becomes really difficult. All parents see is the child, I think.
A few differential diagnoses to consider. The common mimics include positional discomfort, sore leg muscles, ligament sprain or tendon strain, positional ischemia, that is numbness, and dermatitis, bruises, growing pains, or even ADHD for that matter has been associated. Less common ones include leg cramps, arthritis, orthopedic disorders, peripheral neuropathy, radiculopathy, myelopathy, fibromyalgia, and complex regional pain syndrome, or even sickle cell in a case who's known. These were the studies that ma'am was talking about. This is taken from restless sleep in children, a systematic review.
Let's briefly tell you that this is a systematic review published in 2021, which is on restless leg syndrome in children, the total one. And in this, they have described 3 trials they have studied, which had association of asthma and restless leg syndrome. Next slide, please. Yeah, so these are the 3 studies in which you can see that you can describe Khusboo, the number of patients which were there in each study. And the first one showed that restless legs, let's call it RS, in 89.5% of poorly controlled asthma, 50.4% of well-controlled asthma, and 30.5% of no asthma. So there is like a linear correlation between having asthma, uncontrolled asthma, and poorly controlled asthma. And second study, which was also questionnaire based, in which there were 563 non-wheezing children of 5 to 12 years of age. And it was found that 22.6% of wheezing and 7.8% of non-wheezing. So there is a huge difference between the two. So wheeze has been associated with restless leg syndrome. And then there is a study in which there were 83 on one side and how many? No, these were 860. right?
Yes, ma'am. 860.
So they found that restless leg syndrome in 26% of wheezing children and 10% of non-wheezing. So this is so far the evidence which is available in that systematic review which has been done. But that systematic review has actually missed a study. Next one. Which was the relationship between restless leg syndrome and bronchial asthma. This showed that they had two groups of patients. One had total, I think 80 patients were there in the asthma group and about 50 patients in the control group. And they found that 32% of asthma group and 15% of control group had restless leg syndrome. And the frequency of restless leg syndrome significantly higher in the asthma group, as has been shown. And no significant relationship was observed between presence of RLS and the use of inhaled steroids or use of beta-2 agonists. So this was about the drug correlation, but they didn't find anything. Then significant relationship was found between the presence of RLS and ACT. ACT is asthma control test, which is done at home by the parents, including a peak expiratory rate flow measurement, which if the score is higher, then they have a better control of asthma. So based on that, if they have better control of asthma, then the RLS prevalence is lower in these patients. So, but there was a correlation. So now we have the management. Any other questions or comments on this particular?
It's just a lateral thought. Now, children with asthma will have disturbed night sleep there. So what is the chicken ear and what is the egg ear is just an association. Is it that the asthma is waking them up and then they have restless legs, or whether it's a restless leg and association? It's very difficult to think. And
that with asthma primarily would leading to lack of sleep. They have restless sleep. They don't have that much of restless legs. Now, these restless legs have been diagnosed in this particular all studies by standard diagnostic criteria. There is an international group on criteria, standard RLS diagnosis, which they have used. So if we believe that, then we say that this was RLS rather than the other features which lead to sleep disturbances, which may be associated with RLS. Actually, all these children are quite likely to have other sleep disturbances also, along with restless leg syndrome. So that also should be mentioned by the, I think if you study these papers further, you may find that.
Know that restless leg is associated with deficiency of iron. So were these children also deficient in iron? So whether that was the underlying cause for the, so unless they do, so we know RLS is with ferritin less than 50 and there are kids, even if their ferritin is above 50 and they still don't settle down with oral iron, and you need to land up giving them parenteral iron and they do better because the tissue concentration of liver concentration of iron, the brain concentration of iron is less. So it affects the dopaminergic pathway. So I think in this data, we would probably want to look at even their iron levels and rule that and then give them iron and see if it disappears. And if their asthma still persists, then probably we'll be able to make some conclusion.
Iron deficiency is not one of the diagnostic criteria. And so that is not included as it may be a therapeutic intervention for which it is helpful. But iron deficiency anemia is so common in India. All these children who are there, they may be deficient in iron. So I think the first thing is that you correct their iron deficiency and then see if they're still having their symptoms. So it may be a manifestation of iron deficiency. So,
Ma'am, they've also mentioned that asthma has to first be controlled, like in air. RLS, the underlying disorder has to be controlled. So the study you're suggesting where we cannot control asthma is not actually doable.
So iron deficiency is another state, it is a state which is associated with anemia. And iron deficiency anemia is so common in our country. So maybe, there is a point in associated, it's like pica is associated with iron deficiency. There are so many other conditions like that infantile tremor syndrome is associated with all kind of vitamin deficiencies. So when you don't find the reason, why it's happening, you tend to associate it with several other conditions. But I think we really need to study this further. And I have a very strong feeling that maybe it's related to inflammation. It's something which is an inflammatory state, which once treated would be treated for this.
So for this child, we upgraded his doses for the inhalers to ensure that he had better control. And we also started on iron therapy at 6 mg per kg per dose. There are 4 studies which have reported a dose of 3 to 8.5 mg, which is a higher dose than we use for iron deficiency anemia. This child, the ferritin was normal, ma'am, but we still gave, and he came back 2 weeks later with some amount of improvement. So this was just our experience. This is the evidence from that trial that we had quoted earlier, systematic review that we had quoted earlier with restless syndrome, that oral iron treatment has been mentioned for 3 months to be considered effective in improving the sleep and in even PLMS and RLS. And it is unclear if iron can be stopped when symptoms improve. That has not been studied yet. Benefits of oral iron can be limited for children specifically if they have systemic comorbidities. So they have recommended to treat the comorbidities alongside, as we did for Upchat. This is the Cochranian evidence where iron for restless syndrome, in which they have stated that iron probably improves RLS severity as well as existence as compared to a placebo. And iron therapy may not increase the risk of side effects compared to a placebo, and they're uncertain if it improves the quality of life. Other drugs that could have been considered if this child had not responded were pramipexole, which they, according to this study, had shown that it is effective in treating, but there's more data towards adults than there is for pediatrics, where they're uncertain, because there are studies which lack evidence and they have been probably mislabeled as growing pains. Thank you.
Thank you. Thank you very much. So this is what the clinical vignette is, that you take up a case and you have a symptom which is present and you make a diagnosis of a rare disorder. It's not rare disorder, but a disorder which is less commonly discussed, and that of restless leg syndrome, which does happen in children. And it needs attention, it needs treatment, and it may be associated with other sleep disturbances, and it may be a result of uncontrolled or poorly controlled asthma in this particular patient. Thank you very much.